Hello, everyone. My name is Natalia Sokova, and I would love to today IADS Webinar on perspective on oro-facial aesthetics with Dr. João Malta Barbosa, who is a Prosthodontic Resident at New York University. Welcome, Doctor.
Hello. Good morning. It's really a pleasure to be with you today, sharing this this webinar, which I think is going to last for about 1 hour and 30 minutes. And I'll try to review with you a few steps that I think are essential for us to do aesthetic and functional treatments for our patients. Now, I called it perspectives because, you know, the same image or the same place or the same topic seen by different people or seen by different perspectives may actually look very different. You know, this is my home city. This is Lisbon. It's like one of the entrances of the city from the river, and depending on where you are, you clearly see it differently. You see it differently if you're coming in, or you see it differently if you're going out. So I guess this was the perspective that the Portuguese back in the day had when they went all over the world trying to find new places, and it's the perspective that, you know, that I have when I leave my country to go abroad and to study and try to learn more. By the same time, the Portuguese were actually, you know, traveling to discover new places and trying to find out new lands. Leonardo da Vinci was also studying a lot, and he was actually producing a lot of science. And maybe because it was a time where people were sailing all over the world, he said that those who are enamored of practice without science are like a pilot who goes into a ship without a rudder or a compass and never has a certainty of where he's going. So I would like to take this this quote from Leonardo da Vinci to introduce the lecture today, because I think he actually put things into a perspective that that I would like to follow to guide you through these steps of rehabilitation. So as we've seen here, you know, it's in how Leonardo da Vinci approached things was actually to go take it to a deeper level and study them not only on the outside but also on the inside, in order to produce, you know, very fine art, very good pieces of art. And he actually, you know, the key message here from his work is really that when it comes to aesthetics, it's not only, you know, a gift if you are able to produce something beautiful or not. It really follows rules. And some of those rules we're going to review today. The presentation will consist of mainly two aspects. The first one is going to be where we're going to review the oro-facial aesthetic rehabilitation rules, or some of the guidelines, let's say, for these rehabilitations. We're going to cover a little bit vertical dimension of occlusion, lip analysis, incisal edge position, the importance of the occlusal plane, dento-facial midline, the width of the arch or buccal corridors, the relationship of the teeth within the arch, and also tooth proportion. Now, each one of these could probably be a 1 hour or 2 hour lecture on their own. So, you know, I'll try to keep it simple and but at the same time focus on the most important aspects. And then the second part of the lecture, which kind of happens at the same time, is a classification system, so that we can pretty much approach a treatment or a patient and being able to apply these rules or know how much they apply or not. So we basically will have three categories of patients. One where we will have a complete ability to define these rules, or an almost complete ability to apply these rules. Other situations where they're a little bit more limited, and finally situations where they, we don't really have much of possibility to change anything. We really have to conform to the situation that is given. So this consists of, as I said, a classification system where we will see how flexible it is to apply the rules that I previously mentioned to you. So this is how the presentation is going to be structured. Before we start, I would like to take the time to say that it's not my first experience sharing some of my work with IADS and with the IADS family. It actually started in Portugal in 2013. That's how I met IADS, and then all over the years I had the chance to keep the connection, and I made a lot of great friends in Italy, in Tunisia, and last but not least also in Indonesia, where I had my first experience doing something similar to the webinar we're doing today, because I transmitted my presentation live from Portugal back then, and it's been really a pleasure to share with you guys, and it's I hope it's good for you too. Today I'm transmitting from New York City. Here it's not 2 p.m. GMT. Here it's 9 a.m. This is where I am right now, but originally I am from Portugal, as you might have figured out from my initial presentation. It's this small little country on Europe, right by Spain. You can see there on the map. And this is where I studied dentistry. This is, we can see Lisbon on the image on the right side, across the river. And my university is this this lower part of the picture. That's where I studied, and this is on the left. This is the the preclinical training rooms. So it was really a nice place, and I feel like it was very important for me to get my initial dentistry training there. And I really appreciate all the knowledge that was given to me by my professors there. After I graduated, I actually worked for a while in Lisbon. I worked for 2.5 years at the Lisbon Implantology Institute, which was a very good experience for me, and I've learned so much during those 2.5 years. I feel like the first place where you work is almost as important, or maybe it's even more important when it comes to what you're going to do for the future after you leave dental school, because it's really going to set the tone of how you will see the profession, how you will position yourself towards your patients. It's a totally different environment from a dental school. So it was great. I visited all the time that I go there. I have great friends there, and this is just to show you, where I work. And 2.5 years later, I moved to the United States, to New York, where I am right now, studying prosthodontics at New York University. This is the the department at NYU, and simultaneously I'm also collaborating as a volunteer researcher at the Department of Biomaterials and Biomimetics. This is the lab where I do some of my research, and it's a great experience also to be able to work and study at a place that has such great facilities for for research and really to push dentistry forward and develop new things, which I also love to do. But we're going to focus on our presentation, and you will see that I always try to keep you up to date with this slide, so that you know exactly on which stage of the presentation we are. So topic number one, or rule number one, if we want to say that, it's vertical dimension of occlusion. Now, this is something that we typically get in our complete denture lectures, but to me, it's more than that. It's much more than that. It's really the first impression you have of someone when you look at them. You look at someone's face, and you can see that if the facial appearance is collapsed or not. So it really has a great impact on aesthetics. It's not the typical topic we see approached on aesthetic lectures, but it's really something that impacts a lot on the aesthetics of the face. And we actually see here from some of Da Vinci's drawings that he understood that this aspect, the vertical dimension, really had an impact in the aging of his drawings. So if he was drawing someone older, you can see how he would draw someone without teeth and with very pronounced folds in the face, which clearly represent a loss of vertical dimension. So which ways can we have, or which ways have been described to assess the vertical dimension of occlusion? Well, there are actually a lot. And the problem and some of the confusion with it is that none of these is actually 100% accurate. And more than that, it's actually a range. The vertical dimension is not a specific measurement or a specific spot. It is actually a range, and that maybe is why there's some confusion when it comes to establishing or defining the vertical dimension. Now, the good thing is that we don't have to know them all absolutely. If we do, it's great, because we can use different methods, and we can kind of cross-check to make sure that we are in the right range. But there are three that I would say are mainly used. One is the physiologic rest position, and that basically means that we have our patient relax his mandible or her mandible, and we can ask them to swallow, have their lips come together slightly, and with that we are pretty much looking into a position where the muscles are relaxed. That's why they call it physiologic rest position. Now, we don't expect at this point for the teeth to contact. We expect them to be slightly apart, and you will see how apart they can be. It typically ranges from 2 to 4 millimeters, but it can be a little more or a little less. But 2 to 4 is the number to keep. So we have the patient relax. We see if the lips are touching. Facial appearance looks good, and that there's going to be a little space that we can subtract. And with that, we calculate our vertical dimension of occlusion, which means that the teeth are touching. So that's what we see here on the picture. We see on the left side the vertical dimension of rest. And then if we subtract 2 to 4 millimeters, we will find the vertical dimension of occlusion when the teeth touch. We can later confirm this with phonetics. So we establish this vertical dimension. We set up teeth if the patient has no teeth, or we do a mock-up if the patient has a worn dentition and if we are restoring wear. And then we ask for the patient to speak. There's a few sounds that we can use that give us a good guidelines about how accurate we are on this range. and we'll focus on them a little later on the lecture. And overall, of course, and that's the topic of the lecture too, we'll look at the overall aesthetic appearance of the face, if that is adequate or not. We'll look into the nasolabial folds. We see if they are more or less pronounced. They usually give us a very good estimate if we're in the right spot or not in terms of vertical dimension. There are other methods. Some are using measurements. Some use tactile sense. As I said, there's no method that is better than the others. There are methods that are used more commonly. As long as we have 2 or 3 that we use to check and to be sure that they are in agreement with each other, I would say that we should be fine. So this is the first point. Vertical dimension of occlusion is really something we should not ignore, and it's something that you can read a little bit more about in any complete denture book, and I encourage you to do so because it's really very, very important. The second point is the analysis of the lip. And here is another topic that I don't see so commonly oftenly exposed on aesthetic lectures. It is important because the lip is highly variable, and it's really what it is, the curtain to the mouth. It is the curtain to the teeth, to the restorations, to our work. And it has some variability that we should understand if we really want to master the aesthetic outcome of our treatments. Now, this is the most classic classification of lip levels. It is by Tan, was published in 1984, and he pretty much classified lips into 3 main categories. What he called the low lip line was present in 10% of the population that he studied. And it would happen when less than 75% of the anterior teeth were shown. The average was present in the majority of his population, and it was in about 69%. It is the image on the middle, and we see that on this case, the patient will show 75 to 100% of the maxillary anterior teeth, and they will also show the interproximal gingiva. And last but not least, the last category was what some may call the gummy smile, even though I don't particularly like that term, but it means that not only the patient shows the teeth and the interproximal gingiva, they also show a contiguous band of gingiva above those maxillary anterior teeth. So this, I think, there are other classifications we can follow, but this one is pretty simple. And it's, I think, the one that it's most widely used, low, average, and high smile lines. And they're really easy to memorize. Now, the thing with the lip is that it is, as I said before, very variable. And it's also movable. So there's movement, there are muscles that attach to it. It's actually, there are a lot of muscles involved. And the impact of this is should be seen in a static as well as in a dynamic view. When we talk about the support of the lip, how it keeps its volume, there are really 2 key aspects that we should understand. First of all, what I just mentioned. It is composed of muscles, fibrous connective tissue, glands. That gives it its intrinsic support. And on the other hand, there are structures underneath the lip that also allow it to rest in a certain position. And those structures are the anterior teeth and the alveolar bone. Now, if they are missing, of course, it's not enough for the intrinsic lip support, the muscles and the fibrous tissue, to keep it on its level. If we look into what is the average, what is this lip support average measurement that we would be looking into, it will depend on who you read or on who you quote, but as an average, it typically ranges from 90 degrees, as we can see here outlined on the image, up to 120. So there's some variability. 90 is the typical number we should follow. So a 90 degrees with the nose as a starting point should probably be a good one. But we should keep in mind that, you know, when it comes to dentistry, this is not mathematics. So we like to have numbers, we like to have measurements to follow, but we should always keep in mind that each person is different and that we should customize the treatment to every one of our patients. Now, as we age, and you can see here on the image, and you know, simulating the aging process, people will lose teeth, and they will lose the tonicity on the muscles, and that lip support is going to decrease. So there are a few things we can do to maintain it, and we'll see a little further ahead how we can evaluate it better and how can we put all of this together. As I said, that was a static viewpoint. From a dynamic standpoint, you have to think that now the lip is not, you know, it's not like in a picture. The lip moves. The lip moves when we speak. The lip moves when we chew. And we should really focus also on these two aspects of the lip. When it comes to a dynamic evaluation, the first thing I would like to tell you is that lips are not all the same. They don't all have the same length. And once again, some classifications have been published where lips are pretty much classified depending on how long or how short they are. So the numbers are not important. What is important is that you understand that different people will have lips of different lengths, and those different lengths will have an impact on how much the teeth will show. Because if you see here, for example, a short lip, which was classified according to Zitzman as one ranging from 16 to 20 millimeters, will lead to more tooth exposure. So if the lip is shorter, you will show more of what is underneath it. However, if it is long, from 26 to 30 millimeters, it will actually hide more of the intraoral structures. And on their study, they show that it would show only an approximation of 1 millimeter. So it's a huge, huge difference if we have someone with a short lip or a long lip. And this is very important because we cannot use the lip as, you know, our ultimate evaluation factor for all our patients in the same way, because it will lead to it will misguide us because of this variability. Not to try to make it more complex, you know, but as I said, it's also a moving structure, you know, has a lot of mobility. And another study was published and showed that females appear to have a different range of mobility than males. Now, the values overlap in most of it extension, but we see that from females, it started in 3.7 up to 7.5, in males, 4.6 to 8.2. Now, once again, the numbers are not important. What is important is to understand that the range is huge. It's really, you know, from 3.7 to 8.2 millimeters, it's really something that tells us that we should not just look at the lip and how the patient smiles and how much teeth we see and how much we would like to see to make all of our decisions and to make all of our treatment plan surrounding exclusively the smile and how much teeth we see, and if that follows the, you know, what we expect. We really should consider these variations to make our clinical decisions. And another thing to finish with the lip is that our patients will also have different ages, and we want to give them all the perfect smile, but that perfect smile may be ideal for a 20-year-old patient, but for an older patient like this lady here, it may actually be very different. So we should take into consideration the age of the patient when we are looking into these structures and when we are making these decisions. I'll just give you a brief idea of what changes happen when it comes to aging and the lip and the smile. Some studies have been done trying to come up with numbers of how much does the lip change and the smile changes over time. Now, these studies are difficult to do because, you know, if you're not really following the same person when they are 20 up to 60 years. You have a group of people who's going to be 20 years old, you have a group of people that is 60 years old, and then you look at their smile. So there's a lot of variation. These numbers are not super accurate. But what they've seen was that when it comes to maxillary tooth display, when we compared people that were 20 to people that were 60 years old, that display decreased by 3 millimeters. And on the other hand, the mandibular tooth display actually increased about 1.5 millimeters. So that means that when people are speaking, we'll tend to see, as they age, more of the lower teeth and less of the upper teeth. And that is not because of the teeth, that is because of the loss of muscle tonicity, of the loss of facial tonicity overall, that we'll see kind of this dropping effect in speech. Now, when it comes to smile, interestingly, on this particular study, they saw that there were no changes, but they say it's no changes in the combined tooth display. So what does this mean? It doesn't mean that we're not, you know, that the smile is not changing. It actually is changing. But the amount of intraoral structures we are seeing, the amount of opening or unveiling of those intraoral structures doesn't change. Okay, so I really, you know, I want to make this point clear. We'll typically see more of the mandibular teeth. The overall smile unveiling of these teeth is not going to change. So what will happen is that actually, it's like if we try to think about it, it's almost like if the smile came down a little bit. We see less of the upper, more of the lower. It opens the same amount, but all the muscles lost tonicity, so it's kind of like positioned lower in the face. It's something like that. I think I made myself. I think it is clear. If not, you know, you can always ask me some questions about it. At the end, I'll be happy to answer any doubts you may have. This is something that our patients don't like. You know, this aging process they don't like, so they will look for treatments to try to keep their lip and their face in the right place with the right tonicity or with a young-looking tonicity. So at this day and age, you know, a lot of our patients will actually look for anti-aging treatments, and we should also be aware of that. I'm not here, you know, some of our colleagues actually do some continuous education courses to learn how to do them. You know, I'm not saying that we should or that we shouldn't, but we should really keep into consideration that some of our patients will present at our chair, not our office, with lips that have underwent some of these treatments. And that may actually, once again, create some problems in terms of the evaluation, because the lip can actually become distorted. The movement of the lip can actually be affected. So if we are trusting, once again, the lip and how the smile looks like to build all of our dental treatment, you know, we may be mistaken by a lip that is not giving us the right information. So the take-home message when it comes to the lip is, yes, it's very important. Yes, it's what's going to show the teeth underneath, but we should not just use it as the best reference to make all of our clinical decisions when it comes to deciding where the teeth need to be for the smile to look good. Okay, we really want to make it functional. We want it to last as long as possible. So we need to understand these variations, and we need to customize our treatment to these variations. Step number 3, rule number 3. Now we'll start looking into teeth. We were looking into the face. We were looking into the transition of the face into the mouth. And now we'll look at teeth. And this is the most critical point. Defining the incisal edge position is the first step when we are establishing aesthetics, when we are establishing occlusal plane. It's really where it all starts. So we'll see how we can define, or how we can be guided defining the position of the maxillary incisal edge. Now, according to Frank Spear, there are 3 main guidelines that will help us determine where this edge needs to be placed. One, as we've seen, is tooth display and lip mobility. And we've also focused already on how this can be a less accurate way of making our decisions and our evaluation. The second is the position relative to other maxillary teeth. We'll talk a little bit about that. And last but not least is phonetics. Once again, it has to look good, but it has to function equally good. And since a few sounds are produced by the relationship of this incisal edge, either with the lower teeth or with the lower lip, it is important to include them in our evaluation to make sure that our aesthetic decision does not have a negative impact on the phonetics and ultimately on function. So if we take topic number 2, the position relative to other maxillary teeth, pretty much what it means is that, on average, if we look at a patient with an angle class 1, we will see that the incisal edge of the maxillary central incisors, it's pretty much leveled with the tip of the canine, and it's about 1 millimeter longer than the lateral incisors. This is an average, okay? Now, not all of our patients are angle class 1. We may have angle class 2 patients. And what this means is that either the maxilla is larger than the mandible, or the mandible is smaller than the maxilla, or both are happening at the same time. So these teeth will tend to over-erupt in an angle class 2 patient. And we see that on this particular patient, we see how the central incisors are considerably lower than the lateral and the canines. Okay, so this seems to be the most seen scenario for angle class 2 patients. And finally, we have also angle class 3 patients where either the mandible is much larger than the maxilla, or the mandible is of normal size, but the maxilla is smaller. And here we have the so-called edge-to-edge anterior tooth relationship. And what it does is that it actually prevents the anterior teeth to fully assume the position we see on angle class 1 patients. So basically, they will touch edge-to-edge. They will not come down as much. And so we will see under-eruption of the incisal edge. Now, why is this important? It is important because we are not going to be able, just by touching the teeth most of the times, to change a skeletal relationship. So we cannot do, for a patient who's an angle class 3, an appearance of a patient that is an angle class 1. The teeth are touching there. We cannot just increase the length of these central incisors on the picture on the right, because what will happen is that as this patient bites down, those incisal edges will be hit constantly before the back teeth touch. So it's not going to work. So, it's important that we understand these 3 classifications of patients to understand that the incisal edge position will vary in between them. Phonetics, as I said before, is what is going to give us the final verdict on, is this going to work or is this not going to work? And there are a lot of sounds we can use. I'll give you here the ones that I think are the most critical ones. And those are the F sound as well as the V sound, and for the evaluation of the incisal edge position, and as well as the S sound. Now, if we take a little time and if we try it ourselves, when we say the F and the V, we see how our incisors touch our lower lip more or less where there is the transition, the so-called wet-dry transition. And that will tell us if we have a good length as well as a good anterior-posterior position for our incisal edge. The S sound is a little different. The S sound actually is allowing us to test how is that incisal edge position in relation to the lower incisors. When we say S, our mandible comes forward and we push the air through this little gap that is formed in between the upper and the lower teeth. Now, the thing with this is that it's actually not, it's not straightforward. I wish it was, but it's not. So I'll give you once again here a little idea of what variations we may find. Once again, we have patients that have an angle class 1, 2, and 3. We spoke about that. It's pretty much how, the size of the maxilla and the mandible may vary. So for the angle class 1, when they are, of normal size, both of them, we will see that for the lower teeth to assume this position where they align with the upper incisors, the mandible needs to come forward a little bit to come apart 1.5 to 3 millimeters so that the patient says this sound S. If the mandible is smaller or considerably smaller than the maxilla, that movement is going to be much bigger. So the mandible needs to come all the way from the back so that the maxillary incisors align with the mandibular incisors to produce the S sound. So it has to move more. There's more movement involved. Not only there is more horizontal movement involved, there is also more of a separation of the arches. And the opposite happens when we have a large mandible in a class 3 patient, where we will actually have, the teeth are pretty much almost aligned already, as we've seen on the previous pictures. So the patient only has to kind of have the teeth come apart a little bit. According to Pound, it's about 1 to 1.5 millimeters to produce this sound S. So keep in mind that, it's very important to understand what angle class patient you have in front of you, because it's going to be considerably different when we look at an angle class 1, angle class 2, and class 3 patients. So they're, they are different, and we should acknowledge their difference physiologically and skeletally, and incorporate that into our decision process and into our treatment plan process. So let's now, we've talked a lot about, theoretical concepts that are important. Let's see how, how this comes together in our classification system. When can we pretty much have the freedom to apply almost, in a non-limited way? I say almost because, it's never fully free, but when can we pretty much determine and define ourselves most of these aspects? When we have no teeth, so regardless if it is a complete denture, classic, very very common complete denture, and it's really regardless if we have implants underneath it or not. So I've included here that it will also work for overdentures. And even for implant-supported full mouth rehabilitations, because basically what they are dentures with implants underneath. So complete dentures will teach us a lot of oral rehabilitation. They are, I think, the best exercise to train and to train ourselves into a lot of these things that we've been talking about. Here's the classical I would say complete denture patient, edentulous ridges. We do our wax rims, and then on the those wax rims will help us determine the vertical dimension of occlusion. We will establish that in this stage. They will also allow us to set the teeth, following the lip and following phonetics. All of the aspects that we've seen, we will be able to define. So, here's an example of another patient for which I did a set of complete dentures, maxillary and mandibular. And you really have the opportunity to set up the teeth, position them, work on the wax, try to make it good, look as good as possible, and then you have the opportunity to do changes because it's wax, and you will find it very useful testing aesthetics, testing phonetics. It's really one of the best exercises for to train aesthetics as well as function. A few views here of the patient at rest. You can increase or decrease slightly the exposure of the maxillary incisors. That will typically give a younger or an older look, taking into account all the factors that we've determined. Here, I would say a shy smile from the patient with his complete dentures. Now, I've said that you almost have the full ability to do these changes. It's not to define these rules. You cannot define them completely free because, and I've also mentioned that a lot until now, you have to take into account where is the maxilla in relation to the mandible. So if you have a patient like this one that we see here on the picture, where the maxilla is considerably smaller than the mandible, you cannot expect to set maxillary incisors that are going to have an overlap, an horizontal overlap over these mandibular incisors. It's going to be totally impossible. You see where the ridge is, you see where the incisal edge of the mandibular tooth is. It's just not going to happen. So you cannot correct a skeletal deformity with a prosthesis. This is something that Professor Gary Goldstein, who's my course director for complete dentures, tells us all the time. It's really not possible to do, and that will have an impact on aesthetics. But if you do something different than that, the prosthesis is not going to be functional. You're going to be harming your patient if you try to do the correction of a skeletal deformity with your prosthesis, regardless if it is removable or fixed. So back to our list, occlusal plane. So we've seen how the incisal edge position is important into starting to look into the teeth, but that's pretty much the front teeth. Now the occlusal plane will be a result of how all the other teeth align when we move backwards in our mouth. Okay, how is that angulation going to have an impact? How the smile is going to become three-dimensional is really up to the occlusal plane. So let's talk a little bit about it. Now, why is it important? Why is it important that we know how to establish an appropriate occlusal plane? Well, it is because it is what will provide the tongue and the cheeks, the buccinator muscle, pretty much, to optimize the function. And I hope this video works well, because I think it really shows how to have an occlusal plane at the right level will optimize the action of the tongue and the cheek that you can see contracting on the side to position this piece of apple right in between the teeth. If this is off in terms of angulation, you will see that it will be an extra effort for the patient to actually take most out of the efficiency of the stomatognatic system. They're not going to be able to put the food in the right place. They're going to be struggling. They will probably adapt, and we see that they do, but we're really trying to do the best we can for our patients. So this is why it is important. It is to optimize function, and to a certain extent, it will have an impact on aesthetics. So how do we define the plane of occlusion? How do we establish it? Well, we'll have anterior as well as posterior reference points. The anterior reference points are that, the front teeth should pretty much be parallel to the interpupillary line. And we also like to have these teeth look good in rest and in smile when it comes to the relationship with the lip, which we've talked about already. And posteriorly, the most classic one is actually the retromolar pad. that is found to be stable over life, or fairly stable over life. So it provides a good posterior reference point. Some authors may say that it is the upper third or the middle. It will vary a little bit from author to author as to where exactly in the retromolar pad, what level will be used. We can possibly, once again, work as a range. We look at it, we see where the half of the retromolar pad is, and then, from that half to up to the upper third, we may actually have a little of range that will actually work. We can also use the lateral border of the tongue, and if you were able to see the previous video, you'll understand why. It is because the lateral border of the tongue will position the bolus over the occlusal table, and so it gives us a good reference of where the occlusal plane should be. And the same is true for the linea alba on the cheek, on the inner side of the cheek. Because it is, once again, a structure that it's working through the patient's lifetime to during function, and so it may be also a good reference to keep in mind. There are other that are mentioned in the literature: the commissure of the lips, the parotid papilla, the orientation of the combination of the parotid of the hemilular notch and the interincisif papilla. There are a few. Kemper's line and Frankfurt horizontal plane are also classic references for the orientation of the plane of occlusion. But once again, and this is, I think, my take-home message for everything, we should really be aware of all of them, because no single method is 100% accurate. So there's not, if you ask me, what is the best way to do it? Well, the best way to do it is to know 2 or 3 ways to do it, and then compare them and see if they are in accordance with each other. If you really want to know a little, go a little deeper into all these reference points, this article that was published in 2013 by Shetty gives a nice review of these reference points defining the occlusal plane. And if you have to have, if you don't have access to it, just send me an email, and I'll be happy to share it with you in case you want to read a little bit more about it. Now, that was from a functional standpoint, but what is the impact on aesthetics? I've said that there's a little range for everything. It's not just a single number that we'll need to follow. So if I have the opportunity to kind of like move it a little bit, what will look better? What will look the best? What will be the most aesthetic presentation for the occlusal plane? Once again, the studies of on these aesthetic topics are typically done by orthodontists, because they that's I would say a lot of their work is done by and guided by aesthetic factors. People want to straighten their teeth, they want them to look good, so they do a lot of a lot of research on aesthetics. And what they've seen is that, once again, if we compare from 0 degree angulation to 20 degrees, the most favorable angulation seems to be around 10 degrees, so right on the middle. Dentists appear to prefer 15, later people appear to prefer 10 degrees more, but so 10 to 15 degrees seems to be the most pleasant angulation for the plane of occlusion. This will, of course, be influenced also by the angle to which you look at the patient. So let's say that you have a patient who's very tall. Most of the people will probably look at that person from a lower perspective. So it will have an impact also. If we have someone who's very short, maybe most of the people will look at that person from above, and ultimately how they evaluate themselves when they look in front to the mirror will produce a visual difference into how the occlusal plane looks like. So, you know, when you give our patients the hand mirror to see if they like what we're doing, you know, it will also depend if we put the hand mirror slightly up or slightly down or perfectly at an horizontal level. It will have an impact on how they perceive the aesthetics. So, you know, sometimes we have to explain and we have to guide them into how they are looking at it, so that, you know, they can fully understand and see what is the impact of this angle on the aesthetics. Last but not least, and you know, this once again is one of those topics that would probably give a lecture by itself. The occlusal plane is or has been described as one of the factors that are included on the so-called Hanau's laws of articulation, or Hanau's quint. Now, this is an article that is typically quoted for complete dentures, and basically what it tells us is that there are 5 factors that will, you know, that will have a relationship with each other when we are doing complete dentures. One is condylar guidance. The second is the compensating curve, the cusp of the height of the cusps of the prosthetic teeth, the incisal guidance, and the plane of orientation. Now, this is, you know, this is you know, this is for complete dentures. But once again, if we know about complete dentures, we'll be, you know, better dentists overall. So when it comes to the plane of orientation, to the plane of occlusion, pretty much what the authors say is that you know, it should be oriented as when natural teeth are present, and you know, it should conform to the patient's anatomy, aesthetics, and function, like we've seen before. Okay, so there's really not a lot of flexibility to change this plane of occlusion if we're really aiming for maximum function. Now, the plane of occlusion establishes how, you know, how we align pretty much the posterior teeth, what angulation we give them. So now, I always like to think, when I'm giving this lecture, I always like to think at the step-by-step of the complete dentures. So, you know, if you do or if you have done complete dentures, you know, at this stage, you know, you're doing your wax rim, you are establishing your plane of occlusion, you've already established where the incisal edge position is going to be, and now you have to determine what is going to be the left side of the arch and the right side of the arch. So that is the midline. You know, you have to define the midline because, you know, ideally, it should be symmetric. You know, the left should be the same size of the right, and the 2 central incisors should align with the mid of the face. Now, that is great when we have complete dentures because, you know, you set the teeth where we want. But when you have natural teeth, you may not be able to move them around. So what is important is that we understand what is acceptable when that ideal situation is not possible. So what is the range considered to be acceptable for aesthetics or for an aesthetic result when it comes to a vertical midline deviation? So if we look at the bottom pictures here, we'll see that you know, we'll have some difficulty understanding what the difference is. You know, we can tell that there is some, but, you know, in the beginning when I first looked at them, I was not exactly sure which one was which. And the reason for that is that we are actually not able to detect very well differences in the midline position when it's perpendicular to the references that we are using, up to 4 millimeters. What does this mean? It means that, you know, if it aligns perfectly straight with the middle of the face, great. But if it moves 1, 2, 3, or 4 millimeters to the left or to the right, as long as the teeth are still perpendicular to an horizontal reference, it's going to be very hard to tell that they are asymmetric up to 4 millimeters of deviation. Okay, so it's great because, you know, sometimes you cannot just have a perfectly straight midline when you have natural teeth. Now, that is not true when we are talking about angulation. And now what is happening is that if you look at the images, it's going to be so much easier to see what's wrong with them. You know, the teeth are angled; they are not straight, and you'll be able to catch that almost at the second picture from the left. And when it comes to the middle one, you know, you can clearly tell that something is wrong. And it happens because we are much more sensitive to this angulation than we are to bodily move left or right, vertically. So the threshold here is much less. It is 2 millimeters. If we are 2 millimeters at an angle, we're going to be able to detect that right away, and it's not going to be considered aesthetically pleasing to the eye. So there's a difference between mispositioning vertically and at an angle. Okay? So once again, we've covered a lot of theoretical information here. Let's take a look at a clinical case to kind of put together all these topics that we've reviewed. Now, for this point, I would like to bring you the category number 2 of this classification system, and that is when we have limited ability to apply these rules. And that will happen in a fair amount of our patients. You know, not all of our patients, thank God, are completely edentulous. So some of them will have some teeth, and we're not just going to extract their teeth because we want to be able to correct everything at once. If they are very off position, we may need to recommend extractions to optimize the final treatment. But the general rule is that if we can't keep teeth, we'll work around them, and let's see how that creates an impact. So this is true for partial removable restorations or rehabilitations. It's also true for fixed dental prosthesis, the so-called bridges, depending on their extension. And it's also true for orthodontic treatment because, you cannot just, if we wish, we would move the teeth wherever we want to, but, they have their bone anchorage. They have to be surrounded by bony structures, so we cannot just move them anywhere we want. We are somewhat limited in what we can do. So for that, I bring you this. This was a patient that presented here at NYU, where where I'm studying right now. His chief concern is not really so much aesthetics. It is, all of our patients want to have, the best possible outcome when it comes to aesthetics, but his problem was a little bit more complex. This is the classical initial evaluation. We're looking to vertical dimension. We're looking to the facial profile. And we try to, kind of put together what we've covered so far. Is the vertical dimension adequate or not? Is this patient a patient class 1, 2, or 3? All of these little factors we will have to take into consideration when we are creating our thought process. But this is the clinical presentation. It's not an aesthetic case. It's a function case. It's a case of pathology. We have osteonecrosis of the maxilla. We have a patient that had implant-supported rehabilitation, that has terrible oral hygiene, that is struggling with cancer and cancer medication, and who is taking some anti-resorptive drugs, and all put together caused him to have osteonecrosis of the maxilla. So he comes to us after previous attempts actually failed to give him comfort and aesthetics and function. So, this is the classical approach. You do your radiographic examination. We determine that the teeth are hopeless, pretty much all of them, if not all of them. But, it's important not to forget what is the chief complaint. And in his case, it is the actual maxilla and the osteonecrosis that he's experiencing. I've included these images because they were the actual only information I had available when it came, for the design of the prosthesis he had. And being trained in prosthodontics, and I was, trained to look into the minor details. And on this very section where you see the arrow, I see that there's kind of like this ledge right there. You know, there's the concavity on the prosthesis. And that may be there because of two reasons that we've already covered. One is that, you know, this patient has a certain age, so his physiologic tonicity may have decreased. Two, he was edentulous. You know, the implants were placed to restore missing teeth there. And they were most likely trying to create lip support with a fixed prosthesis without taking into consideration the need for a good oral hygiene. Add to that the patient now has cancer and needs to take anti-resorptive medications to prevent metastases, has a bad oral hygiene, has a prosthesis that he cannot clean well, that was made this way possibly to improve the aesthetic outcome, and the result was a very high impact on function and on health. You've seen how, you know, how the image looks like, right? So it's so important to think on this, and, you know, aesthetics can have impact on this patient health and then on his quality of life. These are some of the exams that we have available, you know, checking for metastases, because this is, as I said, a cancer patient. And we see here in a combination of tomography with contrast that binds to areas of higher cell activity, that definitely something not good is going on the maxilla, and that needs to be addressed. This correlates well with what we see clinically. So when we have a patient, and this is a side note, this is a little bit off of the main topic of the presentation, but, you know, to a certain extent, we are pretty much talking about treatment planning. And you see with this patient how important it is to define a treatment plan that it's not going to have a negative impact on their health. Okay, treatment planning, what it is, you know, you have to put together so many things in the very beginning of the treatment, all the conditions, all the things that are well, all the things that are not so well, or the things that can potentially go wrong in the future. The more you can do this game of combining all the pieces beforehand, the best care you are providing to your patient. And it also means that you may not be able to do everything. You may need to call other disciplines, both in dentistry and outside dentistry, to help you and to help your patient achieving the ultimate goal of having the best possible result. Okay, if we miss anything, we can have a compromise. And this patient, you know, clearly shows us that something was missing, something's changed along the way, and the compromised result came up. So here, you know, it's pretty much the steps I followed together with the team at NYU to provide this patient with a solution that would give him aesthetics, but more than anything would give him function and would make him able to be, you know, socially interact with other people and overcome this this problem that he presented with. Okay, so we'll go briefly through them. Here's our setup. You know, this is what we do before we actually finish any prosthesis. We have to take impressions. We have to articulate them. We have to establish the vertical dimension of occlusion with our wax rims, and we have to set up teeth in a position that hopefully it's going to be aesthetic as well as functional for the patient. Okay, those are the two goals we have to meet. Now, if we look carefully here, you'll start seeing some of the topics that we talked about. You'll see that I've established a certain plane of occlusion. You will see that I take into consideration, you know, the position of the mandibular teeth and the maxilla to create the anterior tooth arrangement. And at this stage, you know, it's an edge to edge. And it's okay to be like that. You know, typically we would think, okay, let me put my maxillary teeth a little bit in front and with a certain horizontal overlap according to the mandibular teeth. But we can do that. And we can do that because of the amount of resorption that the maxilla went through. We can do that because the mandibular teeth are not in their original position. They are flaring out. So we cannot just ignore that all these processes happened and try to go with that single thought of what is the, you know, how are they going to look as best as possible, okay? Or what have I been taught about aesthetics? You know, the upper teeth go a little bit in front of the lower teeth. We cannot do that for this patient. So let's look at this picture carefully. It's probably the most important slide for this whole treatment presentation to understand what are the limitations and how I've decided that we have, you know, we are able to work with his teeth being hopeless, but for this transitional stage of his life, how can we take advantage of them, keeping them and helping with the prosthesis, okay? Incisal edge position, you know, we've already spoken about that. We see that I've established edge-to-edge anterior tooth relationship because the mandibular teeth are flared out. So I cannot just decide to bring the maxillary teeth even further out if we already have this malpositioning of the mandibular teeth. Okay, so I want to create here a compromise of function and at the same time conservation of his teeth. If I wanted to create an ideal anterior tooth relationship for this patient, I would just have to go and extract all these teeth. But this patient is undergoing osteonecrosis, so I want to minimize as much as possible surgical intervention, okay, at least until we get him more under control. The second thing is the plane of occlusion. And you can see that it's going to be influenced by two things. One, the vertical dimension of occlusion that I will establish. And two, there is a molar on the maxilla. Now, typically this, as I mentioned, this molar would be extracted. It's not actually helping a lot, other than the patient thinks it's going to help a lot because, you know, he's feeling at this point is of loss. He had teeth that he lost. He had implants that he lost. He had half of a maxilla that he's going to lose because of the necrosis that he has. So he wants to keep as much as possible. And as long as that does not impact negatively on what I am trying to provide him, I will be okay with working with that tooth if it doesn't create a negative impact. So when I establish the vertical dimension of occlusion, what I will see is that of the position of that molar with the position of the anterior incisors allowed me to establish a plane of occlusion that I think is fair. You see that it goes through the incisal edges of the anterior maxillary teeth. You know, it follows back to the occlusal table of that molar. And then further back, if you look at the retromolar pad on the mandibular setup, you know, hiding underneath the mandibular setup, you will find that it actually is about half to the top third of that retromolar pad. So I'm crossing all these references and then I'm seeing that, okay, I mean, I don't really know, I don't really believe this is going to be a major advantage for the retention of the prosthesis, but my patient is asking me not to extract this tooth at this point, and I'm seeing that it's not impacting negatively on my decision in terms of treatment plan. Okay, so we decided that it's okay to keep it for now. There is the tooth that I was mentioning too. The anterior relationship, we spoke about that. Overall, this patient, as you've seen on the initial pictures, I would say that he's actually a class 2 inter-arch relationship, but because of the trauma that these teeth went through, maybe with the previous prosthesis he had, with the loss of attachment that they present, they pretty much flared, and right now they create a dental class 3 relationship. Okay, so we will have to know how to position the maxillary incisors to make this work functionally and phonetically. Here is our try-in in the patient's mouth. You see the anterior tooth relationship. We definitely wanted this patient to improve on his oral hygiene because, you know, it was a very significant contributing factor to his current situation. We see here the try-in. He wanted them to be a little wider than the mandibular teeth, and that's okay, as long as he understands that the other color is not going to change. And before we do any surgery, we really try to maintain these patients periodontally and trying to reinforce their home care. It was not so easy for this particular patient, but we saw, you know, some improvement over time. You know, it's not perfect, but it's considerably better. Okay, here is the surgery where the osteonecrosis lesion was removed until we see that, you know, the bone is healthy. This was done at the Department of Oral and Maxillofacial Surgery by Dr. Flesher. I'm doing pros, so I don't do oral surgery, but the key point is really to know when to summon another specialist and another specialty to help you once you've defined the steps that the treatment is going to go through. Okay, and here we see a follow-up at 2 weeks, and we see the prosthesis that we delivered to the patient. At this point, you know, we were pretty confident that we were going to have an oral-enteral communication. So, you know, I relined it immediately to obturate that defect. And overall, we see here the initial presentation. We see the 2-week follow-up, and then we see 2 months follow-up, still with the defect after a small contraction. And now this patient is undergoing reconstruction of the defect, so that hopefully we can close it completely, and then we can provide him with a maxillary complete denture after extraction of that molar that is still there. Okay, so, you know, it's not the typical aesthetics case, not by any standards, but, you know, it's a case with limitations, and it's a case where I think that, you know, we can illustrate fairly well how the decision factors come into play combined in a treatment plan to make decisions that are, at the end of the day, also guided by aesthetics. Okay, so back to our list. We now go into the arch width. Okay, so we've seen the last topic we saw was dental facial midline. So we pretty much defined what's going to be the right side, the left side. We understand that, you know, sometimes it's not that center on the face. It has, you know, some range that we can work with without having a negative impact on our aesthetic ultimate goal. But now let's see, how is the posterior segment of the mouth and teeth gonna impact on the overall aesthetic appearance of our treatment. Okay, so this is, you know, we're going to be talking about arch width. Typically, it's called buccal corridors. You know, the presence or absence of buccal corridors. How does it influence the aesthetic appearance of our treatment? So, once again, studies by orthodontists are typically seen. This particular one doesn't. It was published on the European Journal of Aesthetic Dentistry, and what we see in the bottom pictures is on the left side the absence of buccal corridors, and on the right side, the most right picture, we see very pronounced buccal corridors. So the buccal corridors are the two black spaces, pretty much, on each side of the mouth. Now, this is, these are the same teeth. They just alter the images digitally. They did some Photoshop to increase that shadow on the side. And what they've looked into was, what do people find most attractive? It's not that it's wrong or right. It's just about aesthetics here. So what they found to be least attractive on this particular study were the most pronounced buccal corridors. So, you know, this percentage, what it means is that if we consider from the right to the left commissure 100% of smile width, when 28% of that width is that black space, they consider it to be the least attractive result. And what they find most attractive is actually not for the buccal corridor to be absent, but rather to be in between 10 and 15%, okay? So not zero, not a lot, kind of in the middle. A lot of studies have actually been done over time. They are not always in accordance with each other, but I think we can kind of take home a general trend. Some say that minimal buccal corridors are preferred. Some say that they don't influence anything, the smile aesthetics, and some others confirm that. In 2007, Martin and colleagues found that it actually has, if they are small, they actually are significantly more attractive than if they are large, which kind of like is in accordance with the study that I previously showed you. And this one, I think, pretty much summarizes it well. It says that minimal and excessive buccal corridors were the least attractive. So not too little, not too much is going to be the good balance. At the end of the day, I really feel that there are so many other factors that you take into consideration when we're looking into smile aesthetics. And even though this young lady has fairly large buccal corridors, you know, I really think that she's very, very, very pretty. And so we don't really look at her buccal corridors. We just look at her and we say, yeah, it's a very pretty lady. So maybe they're not so important, and it's a factor that we should know about, but is not really going to have a major impact in the ultimate aesthetic result. Now, looking into arch and teeth relationships. So up to now, we've pretty much defined our arch. Okay, overall, of course, the arch will have teeth, hopefully. But we've pretty much defined how the arch is shaped from an aesthetic standpoint and what factors contribute to that. We now have to put the teeth into position. Okay, so it's like putting the keys on the piano to define where they need to be. So this is a little exercise I did. This happens to be a provisional restoration supported by teeth and implants at a transitional stage. But I've used it to outline what I thought would be a nice shape for this patient's teeth, taking into account that it is somewhat, you know, a limited situation because, once again, we have to look into what is the shape of the arch. We have to keep in mind that we cannot change the skeletal configuration of this patient. But, you know, focusing on the tooth shape exclusively, let's see how we can now design the teeth and put them in places where they're going to look good. So if we separate this into different zones, I would say that from lateral to lateral incisor, if we call this the first zone that we are looking into, we want to have perfect symmetry. As you know, the more symmetric they are, the more aesthetic they're going to be. If we look into zone 2, typically the canines, this is the transition point. This is where the anterior teeth transit to the posterior segments of the arch. So it typically is the tooth that rotates the arch back. We have this front presentation of the 6 anteriors, and when you reach the canine on each end, it's really the tooth that rotates the arch back to define the zone 3, which is, as we've said before, the buccal corridor. Okay? So, keeping this in mind, let's look into the zone of symmetry. we have a few points that that I think are the key points to keep in mind when we are defining the tooth-to-arch relationship, and that will be important for other aspects too. The first one is the incisal edge. We've spoken about that. We've seen how we can position it, how we can confirm if it is in the right place or not. The second point is the so-called zenith, which pretty much is the most gingival point of the clinical crown. It's the uppermost point of the tooth crown. We have the midline, or in this case, it's going to be the mesial contact point. We've also looked into that, where to position it ideally. And we'll then have the distal contact points that are going to define the width of our teeth. And the reason why these points are important is that, if we combine the incisal edge, the midpoint of the incisal edge with the zenith point, it's going to define not only the length of the tooth, but also the long axis of this incisors. And if we combine the midline with the distal contact points, it's going to define the width of our teeth. And these two length and width aspects are going to pretty much define the proportion of our central incisors that ultimately is going to be a very good guideline for the size of the rest of the teeth. So you see, as we go along, we are really seeing how a lot of these things connect. Now I'm talking just about the teeth, which is typically what we see in aesthetic lectures. But we see how it is important to know where to position the incisal edge, how it's important to position the midline, or know where to position it. It really comes together. Everything is connected. We cannot separate these things. If we look at the gingival points, it's this is really based on studies that look into natural dentitions. It is considered to be aesthetic to have the lateral incisors slightly smaller in length than the centrals and canines, about 1 millimeter, according to Stephen Chu, in a study that, if I'm not mistaken, was actually done at NYU. He observed that when the laterals are slightly shorter, up to 1 millimeter shorter, it is typically considered to be more aesthetic. Last but not least, once again, looking into the axis that I've mentioned, and we see the orientation is going to be dependent on the position of the zenith point. For the central incisors, we saw that before. The zenith point should be about 1 millimeter to the distal. For the lateral incisors, about 0.4 millimeters, and for the canines, they can almost be, perfectly straight, with the zenith point being aligned with a tooth long axis. Okay. This is a topic that it's dear to me, but I don't think we have enough time to go into such small details. I'll just, briefly touch upon it, which actually is, now looking within the tooth after defining its size. How can we actually create optical illusions to define transition lines that ultimately are going to define what is the vestibular area? They're going to define the three-dimensional appearance to the tooth, how you can contour the proximal surfaces to give the perception of different widths and different shapes. It's really here now. It's the realm more of I would say art than actual dental science. It should be more like art science than dental science. And if we include some labial grooves or some little cracks or stains, we can actually play a little bit with the aesthetic appearance too, in terms of age and in terms of creating some elements that can actually distract us from things that are not as perfect in the smile overall. when we're doing our restorations. But you know, we won't have time to focus on that. Maybe later, at any other opportunity, we can look into these minor aspects of smile aesthetics. Tooth proportion, that's the last point. You know, so we've covered a lot so far, and tooth proportion is really, you know, finding the right size for these teeth. We can look it into two ways. We can look at teeth exclusively and focus on the intra-tooth proportion, meaning what is the size of my central incisor? It is a certain size, so how big should be my lateral incisor and how big should be my canine, okay? Some studies have been done on this, and you know, there are some ratios that appear to occur in natural dentitions. For central incisor, typically a ratio of length to width of 0.78, which would mean 78% pretty much. For lateral incisors, 73%, and for canines, the same. Okay, so you know, it's pretty much looking at the teeth by themselves. When we look, you know, clinically, how would we see this? You know, I typically like to go looking into symmetry at different levels. I start with the zenith point at the gingival level, and then as you go down through the mesial and distal, and ultimately at the incisal edge, you know, you'll be able to kind of like have this systematic way of looking into it. Here, it's pretty obvious that what is missing is the lower portion of the right central incisor, left on the screen, and where we would need to restore in order to create, you know, an optimal proportion of this tooth. You know, for reference points, we define the length, we define the width, and if we look at the contralateral tooth, we have the width, we just don't have the length. Okay, so you know, it's pretty obvious and self-explanatory, but you know, it's just a way of looking it into teeth in a systematic way. If we start including more teeth on this type of analysis, you know, we'll start catching up the little differences that ultimately are going to have an impact on the aesthetics. It's a way of not getting lost. Overall, when we look at inter-tooth proportion, meaning when we have to define the size for the six teeth, the six anterior teeth, and anteriorly, there are different philosophies on this. There's the golden proportion that establishes a relationship between the width of the central incisor, the lateral, and the canine, following the numbers you see there. So if the central incisor is X, the lateral would be 0.62 times X, and then the canine would be 0.38 times X, always referring to the central incisor. Of course, this is not the actual width of the tooth. This is the width from a front perspective. Okay, so it's the area that we see. It's not the actual width of the tooth. Okay, so if you move to the side of the patient a little bit, of course, this will all change. So this is true for a frontal view. There are others like the golden mean that, you know, establish, you know, the reference is actually the canine to canine distance, and then considering that overall width that is defined as W on the top of the image, if you multiply that by 0.25, you'll have the width of the central. If you multiply that by 0.15 of the lateral and by 0.1 of the canine. And then there are others like the recurring aesthetic dental proportion and the Preston proportion, or the naturally occurring proportion, where, you know, pretty much follow similar principles with slightly different numbers. The red proportion talks about, you know, 78% height to width ratio for the central incisor, and then, you know, once again uses numbers to get to the lateral and canine, and similarly to the Preston proportion. Okay, so what this tells us is that if there are so many philosophies or so many approaches to this, you know, it means that there's a range, and we should be okay as long as we don't violate this range too much. So luckily we have some layroom to play with these things. Now, to finish the presentation, I would like to bring you what I think is the most challenging situation when it comes to being minimally invasive and restore a patient aesthetically. And that comes when we have absolutely no chance to change, to play with the rules that we've been talking about. So on a patient that is missing a single central incisor or a single tooth, regardless if you're going to replace it with a single implant restoration, or if you're going to do a single crown or a single veneer or a composite filling, it's that situation where you have to make a tooth look like the ones that are surrounding it without touching them, because I think that it really distorts the goal of what we're trying to do. You want to touch as least as possible the natural teeth. So this patient presented to us, a young patient that had already lost, when she came to me, the mandibular anterior teeth, and is in the process of losing one of her central incisors due to localized aggressive periodontitis, very aggressive in her case. And we see how one of the central incisors started migrating, and at this point it had grade 3 mobility. It was discomfortable, and it was, for a young patient, as you understand, very disturbing to be walking around with a tooth that was not in its right position. Here are a few more views and excellent documentation by one of a good friend and faculty at the school, Dr. Suzuki. And we see here, overall view of the radiographic presentation of this patient. I would like to bring your attention not only to the teeth, but also to the mandibular configuration. As we can see on the right side of the screen, I've been focusing. And the piercing, of course. There's that nice piercing right there that we see in all of the radiographs. But what I was saying is that, as you can see on the right side of the screen, I've been talking about maxillomandibular relationship a lot of times. And here I note that the mandible is actually very asymmetrical. You see how one of the sides seems more developed than the other. So that will have an impact in our treatment plan, and that will have an impact on what we define as a treatment for this patient. Now, we confirm that asymmetry when we take our preliminary impressions and when we mount the models, the diagnostic models, on the articulator, and you can see how on the patient's right side, which on the screen is actually the left side, the teeth don't even contact. They clearly miss each other. If you look at the left, the picture on the left side of the screen, you can see how the maxillary arch is totally disaligned, or misses completely the mandibular arch because it's so much narrower. It doesn't happen on the left side of the patient, but what it tells me is that for a patient that is so young, I would like to be able to correct this and to provide her with a stable posterior occlusion, so that we can, have appropriate posterior support for the anterior aesthetics that we are to provide to this patient. So this tooth being hopeless, the central incisor, was determined to be hopeless after orthodontic evaluations, after periodontal evaluations. So the treatment plan consisted of extraction and later prosthetic replacement with a single unit restoration. For that, we worked with the Department of Periodontics and Implant Dentistry at NYU, and they've done an excellent job extracting the tooth, as we see here, and also in trying to reconstruct and prevent further loss and actually have gain of both hard and soft tissue structures. So after extraction, they performed a hard tissue graft, and not only that, they also tried to improve the soft tissue availability and did a beautiful rotational flap from the palate, pedicle flap, so that it doesn't lose blood supply. And here is the sequence of pictures that were taken during the treatment. This is also going to be published soon in the International Journal of Periodontics, so we don't have it available as an article yet, but it's going to be soon available as a technique to restore anterior defects after extraction of teeth. The patient is then provided with a provisional restoration that consists of clear retainer with a fake tooth inside it, and we make it in such a way that we assure that there's no contact with with a wound for the initial stages of healing. After 2 weeks, the patient comes back, and this is the presentation. So it's healing pretty well, and you can see how we have the height and the width of soft tissue that ultimately are going to be so important for me to make a tooth that has the right size and the right width, because we really want to make sure that we only need to touch as little as possible the adjacent teeth. Okay, the patient is referred back to the prosthodontic clinic, and at this point of healing, we've decided to create a more comfortable fixed resin bonded restoration as a temporary. I really like to use the black and white pictures to focus on the shape and on the transition lines, and trying to be as symmetrical as possible, as we've seen before, to the contralateral tooth. And when using the color pictures and using surface staining to get the color as close as possible to the adjacent dentition, in making the final color for this provisional restoration. Okay, so this pretty much covered the topics on the lecture for orofacial aesthetic rehabilitation rules. But I would like to give you a little bit more, and this treatment actually consisted of a little different approach in terms of getting the final restoration done. So here is going to be a little extra gift in terms of how we manage the case until the end, the treatment in the patient until the end. So as I said, the ideal restoration should integrate with the other teeth without having to touch them, ideally. So it's pretty fair explanation for what an ideal restoration would be. How can we create those restorations? Well, the classical way is to take some ceramics of different shades and colors and make a stratification technique that it's very sensitive from the from the perspective of the dental technician, because they have to really know how much of translucent to use, of dentin, of all those layers that are involved in creating the optical effects of the tooth, to create a restoration that, in the right hands, in my opinion, will have the best presentation aesthetically. But with these new technologies coming available, and CAD/CAM and new materials like or newer materials like zirconia, there have been some developments on that. And another option these days is to take a block of a material that has different shades. So it's like it has these graded shades along the block, and then tell the computer where is the crown going to be made, and that pretty much defines how much of more intense or less intense pigment we're going to see. Now, this is the technique sensitivity to do a restoration like this is less, because the color is pretty much defined by the level of the restoration in the block. But at the same time, the aesthetic potential is also more limited. Something similar is available with pressed ceramics, like lithium disilicate. Once again, it's different material, different means of achieving a similar ultimate goal. So, to a certain extent, it's not fully custom made. And there are also some pre-contoured blocks that come prefabricated with tooth shapes, and then you just have to mill the surface of contact with the area that you're going to restore. But once again, if it's prefabricated, it's not highly customized. So it's not the aesthetic potential is not the best. Here is just an example of stratification technique and with the porcelain fused to metal, old school selection of materials, or gold standard selection of materials. But to show you that in the right hands, it can actually provide with a fairly acceptable result, even if we are using metal, and even if we are using classic materials that don't have the best optical properties. Metal is not, we don't have that appearance in our natural teeth. But if we have a skilled technician, we can see how he can create that incisal edge translucency. And in a patient with a low smile line, it works pretty well. But our goal is to replace this tooth. This is our ultimate goal. And I've tried to create something that allows us to make a tooth that looks like the tooth she lost, that under different lighting conditions is going to have an optical behavior such as we see here. We have fluorescence, we have opalescence, we have translucency. It's very, very complex, and we cannot do this if we use techniques that have prefabricated blocks and standardized colors. We're never going to achieve this type of behavior. This is pretty much a concept that was created or introduced to dentistry by Dr. Bazos, and that is called bioemulation. And pretty much what it means is an attempt to be equal or as close as possible to nature and to natural teeth. And natural teeth have these two layers. They have enamel and they have dentin. They have other structures, but they are less important for the purpose of our presentation here. And that is really the attempt to create a restoration that looks just like that. So with this goal in mind, we've turned to the biomimetics and biomaterials department at NYU. I've showed you before how the laboratory looks on the inside. This is how it looks on the outside. And we work here with a lot of great people from all over the world, from Japan to New York, including Dr. Tovar, who is a great friend and who helped me a lot during some of the steps that you're going to see right after. Dr. Atri from Chile, who also pushed a lot of the idea that that I'm going to present here to you today. Moving it forward and trying to do more and more with it. Dr. Camila Sampaio, Professor Irata, who is a great friend and with whom I've learned a lot about aesthetic dentistry and about how to think that dentistry really needs steps or workflows that should be simpler and still highly aesthetic rather than very complicated and very difficult to do. But always trying to get the best possible aesthetic result. And Professor Paulo Coelho, guiding us all and pretty much overseeing everything that we do and giving us great ideas and mentoring us there at the biomaterials laboratory. So we want a restoration that has good aesthetic potential, that is has low technique sensitivity to do, and possibly that it's time saving. And there are 3 steps that are going to be involved for this and for any other restoration that we do, which is we have to scan what we're going to do. And when I say scan, it's in a classic dentistry workflow that would be an impression, but this would be a digital impression. We have to design it, which in a classic workflow would be a wax up, and here it can be a digital design, and ultimately we have to mill it. And once again, in a classic workflow, that would mean making it by hand. In a more digital workflow, it would mean having a machine that actually produces the actual restoration. Okay, so the first step would be scanning the tooth, and we've accomplished that using a micro CT scanner that works like a regular CT scan. The difference is that it makes very, very thin slices of the tooth, and when it puts them together and creates a 3-dimensional reconstruction, we have this high definition 3-dimensional digital tooth that we can then separate into enamel and dentin because of their different densities. Like any radiographic image, we're able to tell these differences radiographically, but not lose track of their overall relationship. So we can now work with these files and with enamel and dentin separately, and now we have a digital tooth. Okay, this to do, or aiming to do, a restoration that conforms as best as possible in this so limited situation where we are just replacing a single tooth. Okay, so we want it to be exactly like the tooth that was lost. So once again, it's kind of like a digital bioemulation concept where we go from the theory of trying to do it the same to the actual digital process of doing it the same. Okay, one of the advantages is that now you have a digital file that you can send anywhere in the world. So you just have to choose where you're going to send to, attach it to an email, and in this case, I've sent it to Portugal, where where I work and where I have great friends. And what they've done, what I've asked them to do is, I have this idea. I want to make a restoration that is exactly like the tooth that the patient's lost. I want to see if it's possible to do it. So I want to test it first. I want you to take the files that I got from this cone beam. From this micro CT scan, and I want you to import them into your regular design software for your CAD/CAM restorations, and I want you to put the tooth there, and I want you to mill it to see if what is the result going to be. So they did that. We've milled the dentin and we've milled the enamel, trying to make a testing prototype to see if the idea would actually work. And the ultimate goal would really be, as you've seen on the previous pictures, to have a tooth that would both have opalescence type of behavior as well as a fluorescent type of behavior, so that it could match as closely as possible the natural teeth that actually have these behaviors. Okay, so here's our prototype after it was milled, and we think that it has a fair optical behavior. It may not be exactly the same as the natural tooth, but then it would come to improving on the materials we have available today to try to make it as close as possible. Okay, so we milled the dentin. The enamel we milled in the same material just for testing purposes, but what we've actually did was we layered it with a layer of composite. So we made these indexes based on the natural tooth shape, and then we've made it in a clear silicone, in a clear PVS material, so that we can then position our dentin root and coronal prototype, and then close the index with a top cover, and now you see that the space that is left there would be the enamel. So we put composite. We choose one that we try to be as close as possible, once again, to the fluorescent optical behavior of the tooth, and we light cure through the index so that we make, you know, our layered prototype to see if this idea could actually work in making a replica of her natural tooth. So this is, you know, the tooth is the one, the natural tooth is the one that has the short root, and the prototype is the one that has the long root, and we see it here under different light conditions. And, you know, we were pretty optimistic that this workflow of scanning the tooth with a micro CT, you know, following its natural appearance, milling the dentin and layering the enamel actually could work, you know, pretty well in trying to make the final restoration. And to our, you know, to our awareness, it was never done to produce, you know, an actual restoration for a patient. So, you know, we wanted to test it beforehand. So at this stage, you know, and we remove the provisional restoration. On the meantime, we've worked into developing a, you know, the Pontic site. In this case, you know, with an ovate Pontic that has several advantages over other Pontic configurations. And, you know, we pretty much go adding little by little composite and polishing to make sure that, you know, the emergence profile looks as good as possible as it has been described in the literature. And there's our Pontic design to receive the restoration. And then because we're following a digital workflow, we'll take a digital impression. And one of the questions that I'm, you know, frequently asked is, you know, how accurate is digital dentistry? How, you know, how are you sure that, you know, this new technology is actually as accurate as the classical workflow? More and more studies are being published about that, and what we see is that it will actually depend a lot on the scanner that we are using. This was an investigation done by the American Dental Association that evaluated 6 intraoral scanning devices, and they test them pretty much for accuracy, which means how close is the scanned file physically to the actual tooth that is being scanned. And then for consistency, which pretty much means that if you scan that same tooth 2, 3, 4, 5, 6, 10 times, how many times is it the same? You know, do you always get the exact same dimensions? Do you always get exactly the same? There's always a little variation, in the same way that if you do the same impression 10 times of the same tooth, you know, it's going to be very, very close, but it may not be exactly the same, even though ideally you would like it to be. So it seems like, you know, some scanners are more accurate than others, and some are more consistent than others. So the scanner is going to play a very important factor. And then if you decide to go, you know, to create physical models out of these scans, it will also depend on how you get those models and on the printer you use. We're actually doing some research on 3D printing right now at the biomaterials department, not only for dentistry, but also, you know, as I was saying, for the medical field. And whenever you know, surgeries need to be planned ahead of time, you can actually take digital images like cone beam scans and other images and produce physical models that can help you, you know, prepare those surgeries beforehand. So these are other fields of research that are being done right now. But for the purpose of our clinical treatment, you know, we take a digital impression, and you can see here how I prepared minimally the palatal aspect of the tooth that is going to be used as an abutment, the central incisor. It allows us to evaluate occlusion in a less conventional way, you know, than the one we are used to with articulating paper. Here you have, you know, markings of where the contacts are stronger or weaker. We want to make sure that we don't have any contacts in the area of our retainer. And once again, because we're following a digital workflow, we have the freedom to send the files to anywhere in the world. And at the time, I was working with in research with Dr. Romanini Jr., who happened to have a great dental laboratory in Brazil. And because he was somewhat involved also in this process, you know, we've decided to send him the files in Brazil and have them help us with the final restoration. And once again, our instructions were pretty basic. We said we want a tooth to look like the natural tooth of the patient. We want perfect symmetry. So we wanted it almost like if it was a flip image of the tooth that the patient had next to the edentulous space. But we have this extra, which is we know how the dentin is shaped, and we want to incorporate that into our final restoration when it's made. We also, with the help of a colleague of mine from the Department of Periodontics, Dr. Urtula, were able to superimpose the two files, the digital impression and the file that was scanned in the micro CT scanner, to tell them exactly how we felt that this dentin should be aligned in the arch. So that's what you see here. You see on white the digital impression, and you see on gray the dentin of the tooth that was extracted in position. And then they send me back, some pictures to make sure that what they're doing is what I instructed them to do, and works pretty well, because they just take some pictures, and later they send me some print screens of the design process, where they basically, what we see in yellow is the the dentin, and then they just have to design the connector to the abutment tooth. Another good thing is that because they have also the information of how the root is shaped, if they have to create a pontic design, they not only can follow the pontic that I've established clinically, but they can also just reduce on the natural root and have a closer approximation to what the natural emergence profile of that tooth is going to be. And then, they follow the process of sending this information to a milling machine and producing a framework that combines both the digital design of the retainer with the shape of the actual dentin. And ultimately, we have to add an enamel layer, so they use also the software to create a mirror image of the contralateral central incisor that is then produced in milled in wax, and then it's overlaid over the tooth to create the final restoration. Now this, as I said, is something that we are currently working on, and creating a database that can make this available not only to who has, to a university that has a micro CT scan like we do, but for people that are working clinically, for this to be also available to make very customized restorations, and that can possibly be achieved through the creation of digital databases of dentin shapes that you can incorporate into the classic workflow of digital dentistry these days. So basically what we're doing is we're taking natural teeth, we are creating micro CT scans of them, pretty much creating digitized replicas of these teeth, and getting the information collected in a database of dentin and enamel teeth, to create customized restorations that follow the natural shape. This is something that we're still working on. And so, yeah, to finish, here it is the restoration after the enamel layer is applied, and you can see as I make the flipped image of the other tooth disappear, how symmetric it is to the actual central incisor that is, it's still present. So you can see the translucencies and more density on the cervical area, where we have more dentin and less enamel, and then more apical translucency when we have more enamel and thinner portions of dentin. As we do this layer in a silica ceramics, we also allow it to have some coverage of the retainer, so that we can etch it and increase our bond strength. And this was actually described and published recently by another Portuguese, Dr. Viana, in the International Journal of Aesthetic Dentistry, and it's a great idea to be able to etch and bond over a zirconia framework. And here is the restoration in the patient's mouth, and a quick reminder of what the initial presentation was. So we've tried to make it as symmetric as possible to the contralateral tooth. And if you look carefully, you can see, you know, that very light incisal translucency and almost the dentin showing gently through the layer of enamel that we've created. Okay, so this was to give you an idea of some of the things that we, you know, we're also working on in terms of what I consider to be the most challenging aesthetic restoration, which is one of the replacement of a single tooth without changing other factors, you know, without changing the surrounding environment, pretty much. So as a conclusion for this presentation, the take-home message that I would like you to keep is that, you know, aesthetics are very important, and we want to give our patient the most beautiful teeth possible, but we should always keep functional considerations into account, because as we've seen in some of these cases, the results may actually be catastrophic if we just use aesthetics as our driving factors for these restorations. The least invasive, the less invasive the treatment, the more demanding is going to be the ability to provide aesthetic restorations. And you've seen that in this last case that I presented to you. If you really want to do something that integrates perfectly with the adjacent teeth, pretty much the options are to have a very, very skilled team that can provide you with the soft tissue, the restoration in the ceramics, you know, very skilled dental technician that can give you the best results, or to try to create, as we are trying to do, a digital workflow that can possibly allow us to get a equally aesthetic restoration without having you know, such a high-end skill from the dental technician, because, you know, to get a dental technician to perform at a very high level takes a lot of years, takes a lot of studies, and, you know, we would like to work with the best dental technicians possible, but sometimes you know, their work is very, very valuable, it's very, very expensive, and we may not be able to afford it, or our patients may not be able to afford it. So we want really to improve on the aesthetics and give you the ability to get great results in highly customized restorations with more easy techniques. And finally, also that, you know, this work that we're doing hopefully will result in creating an improvement on the digital dentistry databases to make restorations that are highly customized, as I was saying, you know, at the distance of, you know, a click on the computer and choosing the right shape of the tooth. Lastly, you know, I would like to thank you for being with me during this Sunday morning for some, Sunday afternoon for others, depending on where you are in the world. And you know, that tells me that, you know, you probably feel similar to me, that dentistry is really a great profession that goes so far beyond what sometimes people may think of it, and that it really can help changing your patients' lives and improving on their quality of life overall. So I'd like to thank you for attending the webinar today. And if you have any questions, or if in the future you would like to keep in touch, you know, you can always follow me through Facebook or through ResearchGate. And at this time of the year, I'm actually now on my way to Portugal. So today I'm going to fly back home. And I would like to wish you all happy holidays and good quality time with your families, and take a little break from dentistry if possible, because it's also important to keep your minds sharp for January when you get back to classes or to the clinic. So with that, thank you for your time, and happy holidays.
Dr. Thank you very much. Thank you very much, lecture, and have a safe flight tonight. But first, first one.
I'm afraid I'm having some trouble.
Metric relation.
I'm sorry. I'm having some trouble listening to your question. Could you repeat that, please?
Definitely. So the question from Imran was, can you explain about centric occlusion and centric relation?
Well, we actually, I didn't focus so much on centric relation or centric occlusion. If the question is regarding definitions, centric relation is really an articulating position regardless of tooth position. So it's the relationship of the maxilla and the mandible, and there are actually a lot of definitions. It's actually if you look into the glossary of prosthodontic terms, you will probably find I don't know, maybe 7 or more definitions of centric relation in what comes to the position of the condyle, some saying more superior posterior, some saying superior anterior. It's at the end of the day a repeatable position for a prosthetic reconstructive convenience. Centric occlusion is the tooth contact that results from that articulating position. So then you establish a tooth arrangement, or you establish an occlusion on teeth, and when they come to touch, when the articulation is that centric relation, you may call that centric occlusion. No. So if the question was in terms of definition, I would say that that's the difference in between the two. It's definitely very important, especially when you are dealing with changing the occlusal scheme of the patient or establishing one for the patient. I don't know if I answered the question or not, but I think that that's the difference.
Thank you very much. The second question we've got from Dima is that, could you please explain further about Hanau squint?
Yeah, so Hanau squint is, it's pretty much a formula where you put into consideration the factors that we spoke about. It's basically, aims to achieve bilateral balanced articulation for complete dentures, or for dentate patients, if you believe that they should have a bilateral balanced occlusal scheme. So what it tells us is that for each of those factors, you see plane of occlusion, cusp height, if you change one of them, it will have an impact on all the others. So if you change your plane of occlusion, it will impact on your cusp height. So if you are choosing teeth for dentures, if you want to have a bilateral balanced occlusion, and if you change your plane of occlusion, that will, depending on how you change it, if you increase it or if you decrease it, it will actually change how the cusp height of the teeth that you want for that patient. Factors like the compensating curve or the curve of Spee. If you change the cusp height and you want to achieve bilateral balanced occlusion, then we may also need to create more or less of a curve, of a compensating curve. So it's a concept that it's mainly for, I think at this day and age, mainly for complete dentures and achieving bilateral balance and understanding how all these factors will affect achieving bilateral balanced occlusions for complete dentures. However, I think it's probably a very good combination of all these factors that we were talking about, and understanding that ultimately they're going to have an impact on each other. So it's not that you can decide to change the plane of occlusion or the height of the cusps or the incisal guide angle and think that things are going to work exactly the same way. No, they will impact on each other. And I think if you go through that article, and I'll be happy to share it, you will see and you'll understand a little better how all these factors influence on each other.
Perfect.
Okay.
Thank you. The third question is from Babel, who says that, as far as I know, there is a lip repositioning technique that could work with the gummy smile. Is there any lip repositioning technique that could help fixing a low line smile, that 10%?
Well, yeah, that enters the realm of of what I said. When you have a situation that you feel that you need help beyond what your skills are, and that actually goes beyond my skill set. I don't do lip repositioning, but I know of its existence, and if I have a patient that I feel that would benefit from having the lip repositioned at a lower level, I would consider it. I'm not so sure how stable that repositioning is over life. So in other words, I don't know if you do the surgery, how stable that result is going to be over time. I've seen some articles published on that, and I've seen some clinical cases presented on that with very good results. So I would definitely consider that. Now the question was if I know of a technique to pretty much reposition a lip in the opposite way, more. I'm not aware, to be honest. I'm not aware. It's harder because basically you would have to put the lip at an upper position. I don't think there is one, but honestly, I don't know of a surgical technique that does that. But it may exist. I'm not aware. Okay.
Thank you. And last question from Bara asks, out of 4 standards, what's the option for? I'm
sorry, could you repeat that? I once again, I'm having some trouble with your connection, I think. So if you could repeat that question.
Standards, what's the preferred proportion for intertooth relation?
I still didn't get the first part, but I guess it's regarding the proportions of the teeth.
Intertooth.
As a personal preference, I like Preston's proportion the most. However, as I said, it's you'll have to think, when you are defining the proportion of the anterior teeth, there are a lot of factors that will actually limit your ability to change that proportion if the teeth are present. So if you have natural teeth and let's say you're doing veneers, you'll have to take into consideration what is, it's not that you can just decide that I'm going to follow this proportion and I'm going to make all my decisions to accomplish this particular proportion philosophy or you have to look into, how wide is your tooth to begin with? What is going to be the impact if you just, let's say, increase the width of a tooth 2 to 3 millimeters? How is that going to change the emergence profile? Are you going to create a ledge with your restoration that is going to potentially create some food impaction or some difficulty for the patient to clean? So, at the end of the day, what I typically like to do is I like to look into the proportion of the central incisor or the size of the central incisor, and then I'll try to have some flexibility into, I don't really follow a single philosophy. I try to look into that particular patient, see how much can I increase or decrease a certain width or height, and how would that consist of for that particular patient to achieve what I think would be a pleasant aesthetic result. So let's say that, you know, crown lengthening is required or not. Can I achieve a good result with crown lengthening or without crown lengthening? I try to keep it as minimally invasive for my patients as possible. And I also try always to do a wax up of what I think is going to look good, and then to do a mock-up in the patient's mouth to actually confirm if what looks good on the model also looks good on the patient's mouth, and if they like their smile when they see it. So, you know, it's really, I think that with all these rules and with all these concepts, it is very important that we know what they consist of. And it would be much easier if we can say this is going to work all the time, but the honest truth is that nothing of this is going to work all the time. So all through the presentation, I've always said that, you know, you should know them, you should know 1, 2, 3, 4, as many as you can, so that you can cross your references and make your decisions, knowing that it's actually, for a lot of these things, it's actually a range. And ultimately, the most important thing is for the patient to like the result of aesthetics that you're providing them. So, you know, to me, the mock-up, to try in the mouth the envisioned aesthetic result is to me one of the most important steps. And I don't really care so much if I'm following Preston's proportion or the golden proportion. You know, that's really secondary for me. It's not, you know, it's not a rule that I cannot change.
Okay, thank you very much. These are all the questions we received.
Okay.
I would like to thank you very much again for this very enlightening lecture, and I wish you happy holiday as well.
Thank you.
Thank you very much.
And same for everyone. Okay. Thank you.
I hope that in the future you'll be interested in providing us with further webinars. And thank you again, and Happy New Year 2017.
Thank you. Thank you. Bye-bye. Happy New Year.
Bye.
Thank you, everyone. Bye-bye.